Okay, so this is their first module. We've obviously got quite a few that we can go through, and we have the opportunity to build in the content that we want, as well as whatever I've ostensibly put down. So nominally I've got a whole bunch of headings, but feel free to put suggestions and things in on the course page. So you've got two main course pages to look at. One is you're going to have a series of what are called, say, like module 1. If you recall from the main program, you've got various modules. So I've just flashed up this Word document which says module 1, module 2, module 3, blah, blah, blah. So we do a couple of hours each week, and it's all recorded. So you can, if you can't make it, don't worry, you'll just catch up on the recording. And after 4 weeks, we've got an additional little date where if you want to, having had a think about it, if you want to ask any questions, there's like a free form Q&A session. So that's tutorial 1. So I don't give any lectures. However, if you, and I'll show you how to do it, if you have any specific questions that you want me to think about and answer, or you've got a particular sort of case or something, if essentially you let me know before the tutorial, then I've got a chance to, you know, mock up a bit of a talk, or just to look a few references up or something like that. But otherwise there's no set lecture, but there will be little set lectures on each of the weeks. All right. So, but that's good. You'll have a course page, one of them to do with module 1, one to do with module 2. And as you can see, if I remind you, we have 8 modules overall. So when we get to the end in July, you can see the dates there. That's module 8. So you're going to have 8 little modules that you are enrolled in. So you're enrolled into what I'm calling module 1 now, and you're also enrolled into a little general courses, sort of like an overview info page. Just bear with me just for a second. So for navigation wise, I'm just going to be quicker to get to this one. So you've got this is your other general sort of background page. So there's not much on it apart from where the main course information is. The actual content is going to be in all of the modules. So you've got one of them, and they'll gradually appear one per month. Just to flag it up, if you haven't thought about it, there is this opportunity to add on attendance at a teaching clinic. So if you've not looked at that and you've not taken that on board, have a little look at that. And then, because that's something new that we're adding on, certainly for I'm doing a visceral diploma as well. And so they're getting some visceral clinic stuff. So as well as the 3 practical weekends, there is an opportunity to see some patients. All right, let me just get back to the module. So you'll have your module. I've been adding some bits and pieces. So for those of you obviously that have been on this page before, you'll have seen a couple of links appear. As we scroll down, I've obviously now put the Zoom link in that you all found. So that's good, but I've started to add things which are relevant to modules 1A, and I've started to add extra papers and things. Yeah. So you'll find that these sections or topics will just carry on getting more and more and more stuff added to them. So the recording that we're doing now, the recording will be in its relevant session. So today we're doing Whose Osteopathy Is It? We've got that Zoom link there. So in the next day or two, I'll remove that Zoom link, put up the video, and then put up in the next section, which will be this one, I'll put up a new Zoom link for next week here. Yeah. Now I'm just going to point you to this thing with the 3 yellow boxes and this thing called handouts. So sometimes you might not want to scroll through the video. So what you can do is to flick onto this, and you'll be able to go through the slides one by one and see the images. And if there are any hyperlinks on the PowerPoint slides, they'll be able to be accessed here. So I don't know where the first hyperlink is, but anyway, not to worry. You'll be able to do that. So the reason why I have the slideshow here is that I don't give, so there's a hyperlink. You should just be able to hover it and click on that to get that additional resource. So the reason that I don't put the ordinary PowerPoint PDF handout with all the pictures in it is that image rights these days, it's quite complicated, and I can't remember where I got all the original images from a lot of the time anyway, so it's just simpler to put the slideshow on and then simply give you a handout, which is the notes only. So you can download the handout and you can see that this has the text of the slides. This will help you navigate to wherever, roughly on either the slideshow or the video, if you want to go back and find something. And again, sometimes there are hyperlinks which should show up. Can't see for looking for the minute. Sometimes the PDF doesn't, but you should just be able to copy and paste again to get that hyperlink. All right, so there's always going to be a slideshow and there's always going to be some handouts, and there will ultimately also be the video. And I'm going to put just the plain audio file up so that you can listen to it, you know, on your phone in the car or something, whatever. So logistically, that's how the course is going to work. And when we come closer to December, I will add in a practical weekend extra module, and that will have a mini orientation bit of content about that, the style of that weekend and how we're going to manage it. So gradually your little dashboard when you log on will just get fuller and fuller and fuller. So any questions so far about the actual logistics of the website? Or are you all okay?
All clear, thank you.
Yeah.
All good.
Good, good. Alrighty. So let's come to what we're going to have a little.
There's only one thing, to be honest, that I'm not clear about.
Yes,
We're all talking
yes,
about
yes.
this October thing.
Yeah,
which I'm
just
not sure
yeah.
what that is. Oh, sorry, could you hear me?
Yes. So with your program, you have essentially bought all these Tuesday evenings worth of lectures, which you can listen to live or recorded, plus you have 3 practical weekends.
Yeah.
So there's one in October, one in December, or no, whenever it is. Anyway, it's I forget off the top of my head. There are 3 3-day weekends, and you're a small group, so I've added on a visceral diploma, and I've also separately flogged weekend 1 on its own and separately flogged weekend 2, just to get the numbers. So because it's obviously quite expensive to get down to London, blah blah blah. So all I was saying was that there are going to be some other students whose programs have been designed to match with what you were going to be doing in that practical, and I've just sort of I've put different words and different headings on, but so there'll be other people other than you 8, just so that when you get there and there are loads of people that you've never seen on the webinars, they've just come up from different courses.
Okay, so we're basically still talking about at the moment of those 3 days, which we bought 3 times 3 days, which we already bought from the beginning, which we might have other people in, and that's one thing. Plus, you were saying you're doing some other courses about visceral and so on, which.
Well, yeah, because so they will have come from other programs that I have now put on to try to accumulate some numbers to cover all the costs.
Lovely. Thank you so much. Sorry for asking that.
No worries.
No, if I can also butt in slightly ignorantly,
Yes.
I said yes to the October dates, you know, enthusiastically earlier, but I'm still not sure that I know when that is. So I think I thought of those as being the December ones, but yeah, at some point maybe.
No, it's probably is December. Oh, sorry, I've got so many courses,
Okay.
so many different venues. So the easiest thing to do is let's just.
No, I hear you. I think that's fair enough. I think these are the 3 days in December that were the first plans. Yeah. In which case, I'm happy to. Sorry.
Yeah, I had the same understanding. One, and then April, and then July.
Yes, that's it. Yes. So we are talking about the same thing. Yeah. Yeah. So December, April, and July. Yes. So ignore all references to the word October. All righty. Good. So, well, let's kick off. So we are recording. I'll just make sure. Yes, that's good. Yeah. So it's been an interesting one to work out how to actually kick it off. So everybody, even if you've all gone to just one school, everybody has their own personal ownership of osteopathy and has their own wish list as to what they want to get out of their professional life and all that sort of stuff. So there are as many osteopathies as osteopaths, but my key aim is to change your way of thinking about why that's a problem, because everybody thinks, well, you know, if everyone does it so differently, there can't be anything that holds us together, there can't be a common thread, and therefore there is no osteopathic thing. And actually what I'm going to try to show you is that you're looking at that conundrum entirely incorrectly, and that in fact we are all very much linked, and it's going to remain throughout a personal journey, allied or oriented alongside a philosophical sort of practice. So I'm hoping to ultimately reassure you that we are or can all be in communion, if that's not an awkward way of putting it. All right. So one of the questions that we want to ask ourselves is, whose osteopathy is it anyway? So most people these days are taught that A.T.Still and early osteopaths, it's all pointless trying to read their writing. It's all nonsense. There's no evidence and it's all useless, and that things have moved on. Science has accumulated new information, and so just forget all the old stuff and move forwards with the new stuff. But so for a variety of reasons we'll explain that's actually not very satisfactory, and I think it's an inappropriate avenue of education. But let's clarify, because everyone's confused about what are the osteopathic principles then. So is it going to be rule of the artery? Am I going to have a list of 5 things? Am I just going to stick to structure and function? Where is it written down where A.T.Still said what the principles of osteopathy are? And unfortunately, or fortunately, whatever way, he never wrote them down. He never actually framed it in the way of, here's a list of things to adhere to. That's all come later. So if you want to know about osteopathy at the beginning, you've got to separate your head from trying to find out which list is the most perfect, or which of the 5 models of osteopathy, you know, the biomechanical or the whatever, or the respiratory circulatory. You have to put those sorts of descriptors to one side, because they actually don't really help you understand what A.T.Still was about. So I personally, I find the one that's the most useful is find it, fix it, and leave it alone if I'm going to do anything or say anything as to what his version was. Because and because he described things in quite a particular way. It's left things open to interpretation if you didn't quite get what he was trying to say. And so everyone can have their own perspective on what he was trying to say or what they imagine he was trying to say. So therefore what he said has different meanings to everyone. So everyone's going to have their own way of identifying with what A.T.Still said or was supposed to have said and what he did actually write down. And so there are lots of identities, but as I said a moment ago, that's actually not a problem. It's made out to be a problem. And by critics of osteopathic practice and the nature of the professional regulatory arena, it's made out to be something that needs to be ironed out and got rid of, and that we need to be uniform and have a very middle of the road common manual therapy identity. In fact, we can reframe it and I think recapture it. So as I say, I quite like find it, fix it and leave it alone, because to find it, you've got to look for it. So you can't find it if you don't look. And so the first thing to really understand about osteopathy is that it's a way of looking. So fundamentally, we could skip to the end of the course now and say it's all about what you think diagnosis is and what you think you're looking for. What is it in the body that relates to, for example, disease and health? You've got to search that out. So it's got nothing to do with technique. It really has got nothing to do with technique. Obviously, you end up doing things to bodies, but trying to have an understanding that you do fascial or visceral or HVT or this technique or that technique completely misses the point. What you're trying to do is to find something in the body. You've got to see why it's relevant, what's it relevant to, and then you've got to work out how on earth you can fix it. And fix it doesn't necessarily always mean doing a thing to some tissues that locally that you've found. Fixing these tissues might in fact mean that you do all sorts of other things to ultimately bring resolution, etc. So that's the first thing, is it's a way of viewing. And if we look at this lack of a list of overarching principles, and we try and find out what it was that he was writing, we can discern some different things. So A.T.Still never really said, you know, structure and function goes together and the rule of the artery is supreme. He said a lot of things, but essentially what he was trying to do is to find out about the principle of how the body is constructed and how the body puts itself together. So the body has a set of, if you like, key principles around which it works. So there has to be good circulation, there has to be good lymphatic drainage, there has to be good breathing, there has to be good posture. These are things which the body needs. So the body has a set of principles that it abides by, functionally, physiologically, mechanistically, if you like. So rather than, so he doesn't need to list that osteopathy has those things, because osteopathy is merely exploring the body, which is orchestrated around, it's designed in a number of ways, which are its principles of function. And many of the early osteopathic texts, you know, such as, for example, within Littlejohn, he was saying that what osteopathy is about is the diagnosis of disease from the standpoint of interferences with vital activity in the structure, and the way then that the body was interfering with the sort of vital activity. So call that neurophysiology, afferent feedback, interoception, circulation, fluid movement, call it what you will. That the body or the fascia or the tissues or the postural alignment and the motor sensory coordination, that interferes with physiological processes. So it interferes with this sort of like vitalism, which is just, you know, a measure of, you know, how much allostasis you don't have, how much agency you've got in your system, for example, how much reserve you've got, say, you know, how good is your heart rate variability. If you've got loads of heart rate variability, you're quite vitalistic physiologically because you've got a lot of reserve built in, and you've got adaptability built into your systems, and so on. And so all they're saying is, for example, this 1908 article by Littlejohn, is that osteopathy is concerned centrally with diagnosing disease from the standpoint of whatever is in the body that's interfering with all these sort of vital processes. So, and then they later on, people really sort of talk about the fact that Littlejohn, for example, would really define the approach to that. So once you go looking, you've then got to begin to interact with, and his interaction was encompassed with the idea of adjustment. So you help the body and the person adjust itself so that it is less interfering with itself, and it becomes more able to self-organize itself and maintain its own slightly better circulation, slightly better posture, slightly improved, you know, interoceptive dynamics, etc. So there's a constant adjustment. You don't just treat it once and it's cured. You can't just go crack and it's now made into an ideal spinal posture and therefore magically all symptoms have gone. It's trying to bring gradually, and given the circumstances of what you find in the body and in the person and in their life, it's bringing them gradually into a way that they can better manage themselves. So that's always been a principle of the approach in osteopathy. And I think it really does get my goat when people say, oh, biopsychosocial, you've got to be patient oriented. You know, you've got to think of the person and do what's going to help them help themselves. And if there is nothing that osteopathy has contributed, it has always, you know, from its inception, been about bringing the person to better functionality, and so on. And so current osteopaths seem to imply that this is a new thing that osteopaths have to learn, and that we have to learn it from the research from outside our profession, because other people have learned about it through their research and have now essentially are trying to tell us that we need to add it in, but we already had it in there. So it's a little bit annoying when people try to say that there's never been this individualistic, patient-centered thing in the origins of osteopathy. This is a very nice little paper anyway on the historical perspectives and the principles of osteopathy. So I've added you, as you'll see, there's some things will be hyperlinks and some things will be full text articles, which I've added that you can download. So here's that one, Jane Stark's article, lovely little historical conversational piece about things. Okay, so A.T.Still didn't give a list of things that you needed to tick off and do. Okay, that came later when people whom needed in their heads to structure things in a different way, and perhaps to communicate it in a simplistic way, they wanted to create things which ultimately have now been unhelpful because they don't really bring us to an understanding of what osteopathy is. So I think really that the osteopathic contribution is all about, yes, understanding health and disease, but it's, and there's a nice little quote here from Jocelyn Proby. Who's Jocelyn Proby, you might ask? So if you're from the BSO, UCO, He was one of your sort of founder faculties, and Jocelyn Proby made a huge contribution to British osteopathy, and he's almost one of these bridging figures from Little John, the era of Little John, onto the era of you know, just current people. He sort of spanned that gap, and I think he has some really interesting things to say. So I've put a little bit of a video on the website where someone from the Institute of Classical Osteopathy is talking about Jocelyn Proby's contribution to osteopathy. And he said that to understand osteopathy, all you needed to know was that health and disease are conditioned by the mechanico-structural state of the body. So that, I think, is a nice way of saying what A.T.Still was trying to say, which was that disease and various conditions are simply a disturbance due to a disturbance of blood and lymph distribution and of temperature regulation, and that disturbance of blood and lymph and disturbances of temperature resulted from mechanical and structural causes. So in there, you don't have to say that structure and function relate to each other, because that's like a bit of a universal given. You don't also only have to think rule of the artery is supreme, because I don't think A.T.Still actually ever said that personally. That's been a later construct, which we'll discuss on another session. But he's not saying that osteopathy is to do with posture or joint biomechanics. He's not saying any of that. And he's saying that it's understanding how the body creates disease, and that in all so you've got germ theory, for example, you've got terrain theory. The osteopathic contribution is that there is a mechanostructural disease process. So it's contributory to all of the other types of things. So it affects the body and makes the body more susceptible and hinders resolution. So that's really what osteopathy is trying to be about. And so you don't need to worry about, you know, theories of, you know, biomechanics and joint angles and so on. I mean, those things are useful for you to know how to move your hands as you're exploring things, but exploring the joint has no purpose unless that status of the joint and the tissues and the structures nearby is telling you something about this physiological dynamic in the body and how that relates to the person's presentation. So it's not about picking up a joint, wiggling it and think, oh, flexion, extension, or should it be rotation, or should I focus on the ligament or the capsule? These are all the wrong questions. If you pick up a knee and you find it not quite right in some way, you have to think, what role is this aberrant knee function, alignment, implication for circulation, neural feedback? What is all of that doing that the knee is, if you like, feeding into? What is all of that other stuff, circulatory, neural, etc.? What's that doing to the health and physiology of the person as a whole? And if you can try to work on that, then you'll be thinking more osteopathically. So as I said, it's when you see these little commentaries about the history, you'll realize that as people have gone through, they have essentially been trying to interpret bits. You know, they might have started with this bit, someone else has been interested in that bit, someone else has been interested in this bit. And so each bit that people have subsequently explored over the decades since, over the last 120 odd years, seems to imply that once that person's commented on that bit, it's almost as though that bit is what's taken then to be osteopathy. So osteopathy is a collection of bits now, as opposed to a general approach to disease interpretation, a theory of disease, if you like, which people have been exploring parts of. So none of the parts per se are wrong, but in themselves, they don't capture anything about the contribution to pathophysiology that osteopaths say the body makes. So as people have gone on, and they've focused on bits and pieces, so obviously the involuntary mechanism people have gone down their track. The osteopathic lesion people and Irving, Fryette and Core, etc., they looked at some parts. Then you got people like Zinc who did circulation and posture, and so there was another part, and then you got into the sort of spinal manipulative biomechanics when it was much simpler to study the architecture and muscle modeling of a single joint. Each people, as they've gone to explore all their different parts, they've began to gradually use methods of science and exploration that have become further and further away from ultimately how you can interpret the wider construct of the body and disease. So I've got a slide here, and I'm sure some of you have immediately rolled your eyes and gone, oh my God, no, don't want to talk about any of that, which I perfectly understand. At some point over the course of the year, we will try to get a better understanding of paradigms in osteopathy and how though they have been used as an agenda, as politics, for all sorts of intra-professional and inter-professional dynamics and conversations, and that as people have tried to work out what bits of osteopathy are, those bits naturally can be researched more by one method or another method and so on. And often the people that come into the osteopathy umbrella, they have often come with their own prior understandings and perspectives. So there are some people that are really interested in what are healthcare roles. Some people are really interested in the fact that, well, all people value patients, all people value a good therapeutic alliance, all people think that, you know, the body structure and function is going to be related, etc. And all people nowadays pretty much think that the mind and the body are intertwined, but they come from different perspectives. So they're only ever going to look at osteopathy through their lens. And so how osteopathy is described is based on what those people's ontology and epistemology are. And this ultimately becomes a real problem, because what they're not doing is asking the question, what is the method of truth? What's the way of looking at the world that osteopathy has? So where we say that the early osteopaths looked at things like disease and function, later osteopaths, for a whole variety of reasons, have ultimately said, oh, there's no evidence for that, or that doesn't fit where we're going on health systems of agenda and how we want osteopaths to have a healthcare role. They have made choices about how they're steering the exploration of osteopathic research, osteopathic understanding and so on. And that's all fine, but they're not actually exploring the early ontology or knowledge or sort of paradigms. So they've said, we don't need to do that because modern paradigms are this, and let's adjust osteopathy into those modern paradigms. And that's probably where your experience has been, most of you recent grads. You've been oriented to this other world of the way, you know, how medicine should be looked at and how, you know, people should be, you know, supported and so on. Which is, I have absolutely no problems with those ideas, but none of those ideas are actually exploring what the concepts of what A.T.Still's view of body and function, and what early osteopaths like Littlejohn and others, it's not exploring what they thought. And I think there's still some relevance in exploring what they thought, but we simply have to do it from a method and a perspective, if you like, an ontology that is relevant to A.T.Still's constructs. And most modern academics don't want to do that because they want to view things from their own lens, their own perspectives. But as I say, we'll keep coming back to that subject because it is a bit of a tricky one. So around A.T.Still, I mean, obviously A.T.Still didn't magic healthcare ideas out of the ether with no reference to what went on around him. So around the time of A.T.Still and in the 1800s coming up to the 1900s, there were lots of things in healthcare, dubious or otherwise, as you know, and the way that America was structured and the wars that had gone on and the civil wars and all of that sort of frontier life, and also the role of you know, religion and all those things were in the background, and all the poisonous cures, you know, even if you don't think modern pharmacology is a poisonous cure, you know, that historically the chemical approach or the pharma approach was much more poisonous than it is now, in a way, anyway. But there were lots of things around the in the arena that A.T.Still was in, which will have informed him. And I'm not just going to, in this course, talk about the fact that A.T.Still didn't like, you know, the poisonous quackery remedies that were around. I'm also going to allude to other physiological, neuroscientific and anatomical and constructs that were also being developed. So in the 1800s to the 1900s, there was a huge explosion of the way that you know, science and medicine, etc., was viewed, how it was studied, how it explored. And A.T.Still and Little John and others would have had an education, and they would have been aware, in the same way that you read around all sorts of theories of disease and health and function and how best to help people, they would also have been doing this. So they were constantly in an environment of learning more. So they won't just have listened to A.T.Still, they will have listened in the context of neurophysiology and you know, concepts of disease and so on. And if you look at the early writings, many of the writings are, if you like, doing a bit of a comparison and a contrast about, well, this is this theory, or, you know, here's this and here's that, and how does that fit in, and so on. So it just didn't come out of the blue. It was in a way configured and informed by the science of the day, in the same way that these days polyvagal theory, social engagement, heart rate variability, interoception, all of these things are currently informing us as modern osteopaths. That there's no reason to believe that osteopathy wasn't informed by those things. And I think that A.T.Still himself, he was a really incredible first-class observer. He, I think, is the epitome of a reflective practitioner. And so he brought observation. He brought the construct of looking and as a fundamental contribution, because he could see how the body was interfering with itself and hindering health recovery and etc. And when you look at his writings, one of the reasons why he was he's difficult to read is that actually what he was doing, his, like A.T.Still's biography, it's not a set of principles, it's like a diary. It's a journey through his observations and reflections, and it's him giving his personal you know, experiencing and what popped in his head when he thought or saw or felt a thing. He had all sorts of, if you like, ideas in his head. Now, I bet you every time each one of you would pick up the same patient, each one of you, as you put your hands on, would have all sorts of different things pop up in their head. And you feel embarrassed about saying what they all are, and nobody's supposed to say anything that can't be measured or have inter-rater reliability these days. And everybody feels a bit weird saying, well, I think it feels a bit blurry, or it's a bit sort of scary in there, and you know, all these sort of like qualitative words which nobody feels comfortable sharing anymore. A.T.Still had no such reserve, and he meandered along with all sorts of interesting, weird, wonderful and wacky sometimes imageries that he brought to help himself understand what he was doing. So his biography, if you like, his principles and practice books and so on, his philosophy of practice were observation and reflection and personal meaning. So if you read his stuff in that light, I think that you'll get more out of it, because what he's not telling you is a recipe. He's telling you that he's made a series of observations and that he was able to that those observations had meaning for him. So if that's good enough for him as an approach to interpretation, I think that it should be good enough for us. So this is a completely, though, different way of observing the patient. So instead of having a very sort of scientific, medical, positivistic, let's measure the blood pressure. Blood pressure should be this value and this value. We won't worry about if it's male or female because we haven't bothered studying differences in gender. But this is what we're going to measure, and therefore, if this is the measurement, this is the therapy that we apply. And osteopaths don't think like that at all. They would feel someone, or we would feel someone, you know, supposedly there's a blood pressure problem going on, and we'd say, well, what's all that to do with then? Where is that coming from? And what is the impact of that blood pressure having throughout the body? What on earth can I make of what's going on in that person? And so it's that type of inquiry is literally interpretative. So it is not the science of a positivistic framework. And if you want to have a methodology to measure blood pressure and do it positivistically and medically, then you get your sphygmomanometer out and you get your pharmacological pills to adjust blood pressure. If you want to do it osteopathically, you've got to then have a much different method of exploring the idea that bodies are variable and that we have to interpret a unique set of circumstances within a patient. So that our epistemology is that we investigate it from lots of different angles, whereas medicine usually only observes from one angle. So we look at it from lots of angles, and we realize that every time we look, we might get a fresh answer. And that's, so we hold that the worldview is not set. And this is a problem for medicine. So if we literally read these early reflections, we realize that they're coming from a perspective of observation, which is a different, has to be evaluated differently. And that doesn't mean to say we can't use rigor and that we can't reduce bias. It doesn't mean to say that the observations might not be generalizable. It doesn't mean to say any of those things. It just means to say that it's observed in the context that many things we acknowledge will vary it, and that we can't control it in the same way. So I think that was what A.T.Still was really trying to say to people, is that you know, if I do the viewing and then you do the viewing, I'm viewing it with my nervous system, if you like, and you're doing it with your nervous system, and we're bound to look at it differently. I'm going to come back to that point. So essentially what A.T.Still was then doing in his biography and in all of his discussions is that he continued to observe and reflect. And so he built on his personal image of what his hands, what meaning, what his hands were finding had to him. So that meaning deepened and that meaning developed. So in the same way that you as a practitioner, whether you're 1 week old, 1 year old, or 20 years old in practice, you will continue to be building your meaning. And so therefore the richness of your discussion and the number of things that you can sort of wedge into your osteopathic vision will continue to expand and adjust and reflect. So again, when you read A.T.Still's work, it's not a procedure manual which is set in stone, and over 40 years he always wrote the same thing. Actually, as he developed, so did his discourse, and that's a good thing, because that means that we've learned more from him as we've gone along, as he's gone along as well, and that means that we are allowed to add into our perspectives. So ultimately, there's going to be quite naturally a number of different perspectives. So I will identify in one way because I've got a certain perspective. You guys will all individually identify as, you know, from your own sets of experiences. So your cumulative exposures and reflections will lead you to a slightly different ownership and image. So you'll have a personal identity construct in your following of the philosophy of osteopathic exploration. So it's absolutely God-given that we will all have variable identities as osteopaths. That's the whole point, because we all have to be able to look at it from our own lens to work out what we personally are going to be able to do to help that person, because it's absolutely has to be understood that you cannot have two practitioners look at the same patient and come up with the same answer, because those two practitioners don't have the same hands, they don't have the same bodies, they haven't had the same prior experiences of physiology and pathology, and so they can't construct this exactly the same meaning into their palpation and exploration as the next guy. Even if the patient's the same, the practitioners never are. So although they're still looking at physiology, each practitioner will try to work out how to help the body, how to unencumber the person's health and physiology in a slightly different way based on what they've learned up till then. Does that make sense? So this may all be you know, I may be teaching your grandmother to suck eggs in all this, but I think it's worthwhile in our first session just trying to frame a number of things. So essentially A.T.Still had a number of reflections, and he was very good at reading the patient with his hands and with his general observation. He was very good at ultimately getting stuck in and then doing something which definitely made people feel better. And because he was explaining it in the way of personal imagery, people couldn't really work out what he was doing because they wanted a list of instructions. And that's what he was never going to give. So that's when you had other people come along, such as Little John, who thought, okay, well, I've had this background and exposure in physiology. I've come across a load of neuroscience theories. You know, I've followed a few theories of sort of disease and germs. And so he was a more, if you like, academic, more exposed to Western medical constructs than was Still was exposed to frontier medicine. He was exposed to, he had a although both men were religious, A.T.Still had a different relationship to religion, but he also had a different exposure to Cherokee Indians and all of those other sorts of things. So the two men came at A.T.Still's practice quite differently. So people began to try and give meaning to what A.T.Still was doing. And so each time, as I said before, each time someone's come along and has been trying to understand physiologically or neurologically what could be going on. So the latest iteration, of course, is C5, a tactile touch, things like that. So that osteopathy is all about, you know, the tactile, soothing, interoceptive releasing to the autonomics and limbic system, and that's how osteopathy works. And some iterations before that, it was spinal cord physiology, and so on. So each time someone's come along, they've been trying to frame a part of it, and gradually what's happened is that as people have explored osteopathy, they haven't explored its fulsome wondrousness. They've gone down, if you like, narrower and narrower channels, and it's a bit like falling down a rabbit hole. But unfortunately, it's not Alice's rabbit hole where you end up with something wondrous and peculiar and something totally unexpected in a way that's gives exciting insight. It's like Coraline, if you know that one. It's going down a rabbit hole that leads to a very sort of, dark and narrow and awkward perspective that's very difficult to get back out of. And so it's all right looking at things minutely and going down a bit of a rabbit hole, but you've then got to be able to sort of, if you like, climb back out and put whatever you've observed minutely in the context of the whole. And I think that gradually the exploration of osteopathy has not, in fact, gone down the rabbit hole and then retreated into the original vista. It's gone down the rabbit hole, fallen through, had a bad experience, popped out the other side in a parallel universe as a bit of minute understanding, which is now in splendid isolation. And so whomever is still holding that nugget of minute exploration is saying, well, it was supposed to be linked to something else, but what the hell do I link it with now? And eventually, the only way you can broaden it out to give it contextual meaning is to draw on other constructs, other science, other people's practice. So you've popped out somewhere at the other end without being able to now reference it back to the original constructs. So all you can then do, once you've gone down that rabbit hole and popped out into a parallel universe, is take your nugget and vainly try to tack it onto other people's theories. And that's where we are today. It's a compromise, and it's a juggle between, whether we are just a bit of an alternative, just a bit of an add-on, or whatever. So we only become a small thing now, and we've completely lost the original construct, which was that osteopathy was a unitary theory. It had something to say in all circumstances. Originally, obviously, A.T.Still and so on proclaimed that as a unitary approach to health, it could cure everything. Fiddling with the body could cure everything. And I think probably we'd have to accept that these days, nutrition and some pharmacology products and lessening environmental toxins, all of those things do have relevance. So there are other ways of helping someone's health and functionality other than by doing something within their body. So I think that probably the better way of saying it is that osteopathic constructs have meaning in all presentations, rather than they cure all presentations. They will have meaning across all fields of medicine, all levels of depth of clinical pathological processes, and all stages of disease and all ages of patients. So there's something that you can do within the body which is relevant regardless of how relevant other things are as well. And so I just want to reinforce the idea that I do think that we've popped down this rabbit hole and come out into this parallel universe, and that the people that are now exploring osteopathy, as I say, have brought their other constructs. They're trying to match it into other healthcare practices, other healthcare systems, and try to now find a home for some of these constructs. And so you get, instead of having people like A.T.Still, Little John, and some other American osteopaths moving from global body observation into some sort of science understanding, instead of trying to tie a unitary theory together with physiology and perhaps some spiritual practices, these early players were trying to pull together a whole variety of things. And that these days now, unfortunately, the rabbit hole has taken us into certain other universities. So into universities. So for example, one aspect of a unitary theory was that there was an ideal way that the body was designed. So, you know, the body was put together with 2 arms and 2 legs, a heart at the top, a diaphragm at the halfway down, your bladder was at the bottom and so was your prostate, but your brain was at the top and your eyes were there. That's an ideal posture. That is the way the humans are designed. And so actually, physiologically, if it can maintain its health, it maintains its health within that form. So you go from that sort of ideal posture to a slightly narrower vision of, well, what's posture, function, and deviated postural function and health. You go from that to a slightly narrower lens again, where you look at applied biomechanics and spinal movement, which then very rapidly takes you into just musculoskeletal medicine, such that now what was a unitary theory of posture and health has been just turned into spinal biomechanics. So when you try to say that spinal biomechanics help all presentations of disease, of course it's a nonsense, because there's no way of tracking back from this perspective of spinal biomechanics into a unitary theory of disease. Even if you are thinking of treating the spine, so obviously A.T.Still spent quite a bit of time treating the spine, so because people saw him do it, and others osteopaths in those early years also treated the spine a lot. So there's clearly something, you know, interesting in the spine that they all thought and observed. But they originally were looking at the spine and the body and etc. And they were looking at spinal movements and interactions as a physiological phenomenon. They were trying to, all their early writings is about how does this tissue vertebral complex relate physiologically, for example, into the spinal cord? How does it relate to the circulation within the spinal column, such that the circulation onto the nerves in the spinal column could then be good, because you needed that good circulation of the nerves in order to process all those nerve signals. So all the nerve signals to the viscera and etc. were all good. So they didn't look at spinal biomechanics in the same way that nowadays, through the rabbit hole, the way that others now look at spinal biomechanics is that there's a facet joint, there's a disc, it's made up of certain tissues, it can be ruptured or not, nobody knows, there's lots of pain fibers all around, and when you sort of manipulate the joint, we just, you know, it has this range and you can do this, and it doesn't matter what you do to it because it still hurts or whatever. So the understanding of just the biomechanics of joints and discs, and whether you should have, you know, a fusion or IDD therapy or, you know, injections or whatever, those now cannot be related back to how the spinal column functions physiologically for the physiology of the whole body, not just for the health of paravertebral spinal musculature. And so what you're left with is, once you've shrunk your unitary theory of posture down into, you know, some biomechanical understanding, and when you've understood that the biomechanics are, you know, all a bit, you know, facets face different ways, they can't be uniform, bodies grow in individualized ways, so there's no consistency, so you can't do anything constructive biomechanically because all the anatomy is so variable. When you have that, you can't really do much with that, so you have to now add back on things like a movement function, rehabilitation, theories of agency, getting the person to help themselves, empowering someone, and patient-centered care. So you climb back out of a rabbit hole by now tacking on other things which also have meaning, but they weren't what went down the original rabbit hole in the first place, which was all of these constructs of a mechanistic interpretation of physiology and pathophysiology. So it's no surprise that modern osteopathic academics have to fart around with all this stuff saying you should be biopsychosocial medicine and you should help your patients help themselves and have function in movement and, you know, be better adjusted to the fact that their function is adapted and not ideal. So they come up with those things, and that osteopaths should have healthcare roles which are supportive of the wider person and, you know, etc. So it's no surprise that they end up saying those things, because what else are they going to say? Because they have no reference point back, because they went essentially down the wrong rabbit hole and they followed a sequence of people and evidences. And each of those evidences have made small errors, and it's been a compounding error over the last 50, 60 years to separate these original constructs from where we are today. And this is quite an interesting paper, because instead of A.T.Still and Littlejohn and other people guiding what osteopathy is now about, we have other people which have popped back out their own rabbit holes in their own, if you like, parallel universes of experience and understanding, and that those are now the players which are defining what osteopathic practice should all be about. But they have their own agendas, they have their own ownership of you know, their own paradigms, whether they're quite positivistic or medical in their own perspectives, or whether they're quite intuitive or interpretative. They'll all vary, but there's actually quite a small number of people, when you look at it, that are now framing. So there's a small body of people, they all talk to each other, they're all sort of like part and parcel of similar institutions, and they all move between different roles across just a few little institutions and things, and they contribute quite a lot to the majority of the discussion and promotion of what osteopathy should be now labelled as. So this is actually a really interesting paper, whereby they've tracked whom is publishing the most, what they're publishing on, and if you're talking about framing osteopathy, there are just a few players, and you have to ask yourself, what are the agendas of these varied authors, and what are they trying to say? What are they trying to push the profession in towards? Why are they doing that? What are they trying to achieve with that? And so they may have very laudable aims, but those aims may be an extremely long way away from researching, exploring, critically appraising, and considering through appropriate methodologies what early osteopaths were all about. So when they say there's no evidence, it's because no one's looked in general, and no one has looked in ways which are relevant to the you know, approach to practice and the understanding of truth and so on. And that you can't just say, well, there's no evidence, so therefore we have to move on forwards in a different direction. What I want, and I know lots of other osteopaths want, is that actually we continue to we find a way back out through the rabbit hole the other way. We pop back up and we begin to explore this original construct to understand what value it has in the modern world. So that's really what I'm hoping to achieve. So whomever is currently commenting, they're on their own journey from their own perspectives, and each time they're looking at it for their reasons in their way. But that should not define the way that we look at it, the way that we can look at it or should look at it. And there is no reason why the commentary and understanding that we do, the collective we, the royal we, there's no saying that these people, just because they're looking at it in a modern, they're looking at their view in a modern construct, there's no reason to say that that is now has to be any more osteopathic than the lens that we look back on, because we're not looking at it inappropriately, but we're understanding, we're not looking at it through the distortion of people's bad research, misinterpretations, and sort of small summaries which have sort of lost the plot as it's gone along. So if we skip back at the beginning, essentially it's a way of seeing. This is what osteopathy is. It's a way of seeing what's going on in the body, and so it depends essentially on what you're looking at. What are you looking at in the body? And what meaning can you make of that? So people are often taught that we've got seeing fingers, haven't we? We put our hands on and we have all these palpatory experiences. Yes, we do. And we'll all describe them with our own flowery language, and that's fine. And because people are living, you know, if I go to touch someone's body and you know, they're okay with that, and someone else comes along and touches their body and they're not okay with that, you know, their tissues will freeze up or distort, or someone else will come along that they like more, and so their bodies will react quite differently when that person touches them. Each time someone comes along and touches them, the person's body, even if their anatomy is the same, the responsiveness will be different. So anyway, we're all going to have slightly different experiences when we touch the same patient. But when we're looking at it, the point of the exercise is not just to find the palpatory outcome. So whether it's mine or yours, you know, just feeling that it's tight or tense or floppy or saggy or puffy or whatever is not the point. Let's just have a look at this for a minute. So what is this? Okay, so you can hands up to yourself. Who sees a duck and who sees a rabbit? Who can't see either and who can see both? So this is obviously quite a famous psychological sort of experiment, if you see what I mean. And so what you have, good, some people can see both, which is excellent. I'm hoping that more of you will learn to see both, because that means that you are flexibly minded. And the point of an osteopath is that you have to look at it in different ways. So you have to say, right, okay, these pen lines never change, but if I skew my head somehow inside my head, I can construct them in one way, or I can construct them in another. So if you take these pen lines to be, you know, bits of tissue in the body, bits of scarring, bits of this, bits of that, bits of anatomy, bits of structure, and you grab hold of them, and then you mentally construct them one way, and then you think, hang on, you shift some gears in your head, and suddenly those tissues reveal themselves in a new way. You've viewed them differently, so you have a new perspective. So osteopathically, actually, you should all be doing duck rabbit. You take your tissues and your bits of body, and you go, okay, click one view. So is it duck, rabbit? I think there's a few others that people come up with as well. But the point is, you know, if I'm a duck oriented person, I'm going to interpret them in that way. And if you're a rabbit oriented person, you're going to interpret it another way, even though the tissues are the same. So the skill of the osteopath is to be able to move between many such tissue illusions, if you like, but the illusions are in your head, and that you have to learn that the reflections you have, if you can't view it from any other way, if you've only got one view of the fact that the joint bends like this and the tissues are tight and you have to press on it and there's a trigger point left of it, if that's the only thing that you can think of, you're not viewing those tissues in an osteopathic perspective. So what A.T.Still's early writings are all about is he's describing all these images. He's saying, I see this, I see that, you know, I thought of this, it made me think of this, here's a story about the other. And he says things like, I see all the veins and arteries, and I see all the lymphatics, and etc. And he's constructing them variably from all sorts of angles to work out what meaning would that have for the physiological processes going on? So you've got to think about it from a respiratory point of view, or think about it from a blood pressure point of view, or think about it immunologically or sensorially, or in terms of allostatic load, or whatever. And you've got to, in your head, constantly morph your way through different iterations and interpretations of the body. So I'm hoping that you'll see that when viewed in that way, that a list of techniques that you have to do to differentially diagnose the knee as to whether it's a anterior cruciate or a posterior cruciate are totally missing the point. Who cares? Doesn't help you understand how you're going to treat. Just because you can label it this tear or that tear, you know, is you know, so what really? You might be able to strap it this way for one, strap it that way for the other, but beyond that, what else is going on that the body's trying to do that it would help its own self-resolution, and what's getting in the way of that? So that's what you're trying to understand. So when we are looking at these things, we can't use a type of observation which is based on inter-rater reliability per se, or it's not about measuring angles of joints. It's about trying to look at the context of what's going on. So these days, people have gone all the way through. They've left a trail of breadcrumbs, if you like. They've got a bit lost in the forest, couldn't see the woods for the trees. And unfortunately, people have been pecking away at all these breadcrumbs over the years, trying to say, oh, well, this is no good, that's no good. Well, there's no evidence about that. That research is so poor. And they've left us with a very thin trail of breadcrumbs, if you like. But I think that we can still nonetheless see our way home. And I'm going to put this picture up. I'm more than likely, I'm sure you know these things. It's the guy that points at the moon. Of the Buddhist tradition, say, oh, look. Yeah. And what people do when they sort of talk a lot, or they discuss things, or they say, look at the findings of the biomechanics of this, or look at this research item for this. They're asking you to look at something. In other words, they're asking you to look at the person that's speaking, pay attention to what the person's speaking at, rather than some of the bigger contexts all around. So this looking at the moon story is don't look at me, look at the moon, is all about, in an osteopathic context, is saying, okay, so what if that bit of research says that? What's the context? You have to not lose this ability to stand back, look at the whole, and how are you going to place that bit of research and that bit of information in this context? So we're trying to find our way back so that we can look at the whole paradigm. So we don't want to look in a small focused way. We want to look at this wider unitary concept, the paradigm of practice. Our paradigm of practice is that the body contributes to the etiology of disease and conflicts with recovery and self-regulation. That's the context. So that's what we're going to find. Okay. So we've mentioned A.T.Still, who was obviously American. We mentioned Little John, who founded your school if you came from the BSO or UCO. There are a whole number of people. I've mentioned a chap called Jocelyn Proby briefly, who was a faculty member. I'm going to mention another faculty member, Audrey Smith, who was principal at one point, so you may never have heard of them. The point is, she did the osteopathic sieve and the pathological sieve, which were ways of helping you differentially diagnose. And so on the surface, it looks as though she's quite a reductionist person, because it says when you differentially diagnose the knee pain, you say, is is it cancerous? Is it infective? Is it viral? Is it muscular? Is it neurological? Is it osseous or whatever? So there are all these tissue types, and there are all these types of pathological processes like you know, cancer or infection or trauma or so on. And so it looks as though osteopathically, what you're supposed to do is just to say, well, there's no signs of an infective problem of the knee because it's not hot and there's no night pain. There may well be a traumatic injury of the knee because it's misshapen, lumpy, bleeding, and they've told me they fell over. So, you know, you can view Audrey's osteopathic sieve as something which is reductionist and just whatever, it leads you to a tissues causing symptoms paradigm, which just says, you know, pain in knee, anterior cruciate ligament, strap it up, do exercises, and that's about all you can do osteopathically. However, what in fact you can also reflect on is to say, how are these tissues behaving? What processes are going on in the body? And as I'm looking at each tissue with each process, how are all of those adding together and irritating each other? So a case history is about, or understanding a case, it's a way of looking and gathering information by trying to ensure that you are taking a multi-layered view of the patient for their current presentation. So you want to find out if this person is someone whose immune system is exhausted. You want to find out if someone is prone to trauma because their muscle tone overall is weak and they've lost balance and have no proprioception. You want to find out if they're emotionally constrained and have psychological overlays to their pain perceptions. So actually, when you go through tissues and processes, it's about adding them all in together, seeing how many you can find, which is a completely different process than saying, is this a cancer and should I just refer them without even putting my hands on? Is this something that is unsafe for me to treat, therefore I won't do anything and I'll refer them on? Because usually tissues causing symptoms, paradigms and diagnoses lead you to down to a certain risk-benefit equation or certainty of diagnosis or uncertainty of diagnosis. And if there's any uncertainty of diagnosis, therefore you do nothing, you refer on so that someone else delivers a certainty. But those types of diagnoses are not osteopathic, they're allopathic, because they're not trying to understand the processes. So I actually think Audrey Smith has got a very bad press because people have misinterpreted her or used her work to suit an agenda of medicalizing and standardizing a certain tissues causing symptom paradigm, which of course has led to the General Osteopathic Council, if you're in the UK, to having a standards of practice and fitness to practice paradigm, which says if you don't follow this tissues causing symptoms and provocative pain testing and orthopedic testing to make your diagnosis, then you're not doing what we say osteopathy is, so you're not fit to practice, so therefore the GOSC will strike you off. So people have used things to create now a regulatory framework which suits those perspectives, which absolutely now conflict with earlier osteopathic constructs. So what's being regulated now, of course, doesn't match the earlier paradigms. So that creates an interesting problem for how you choose to practice. So obviously that's quite stressful for people. Okay, but when you take a case history, I don't know, it may all be different now. You may be doing it electronically, so there is no such thing as page 2. You have to scroll down a bit, but usually page 1 of 2 sides of A4, you folded your A3 piece together, you folded it together, front page, name and address, presenting symptoms. Page 2 was past diseases, past surgeries, past accidents, you know, blah, blah, blah. Page 3, examination, osteopathic ideas. page 4 on the back, I did this, here are my thoughts for next time, and here's where the tutor signed it. So there'll be some sort of thing whereby we always used to call it page 2, which means that you rule out all the pathologies. You ask your page 2 questions to find out how many ways that you can essentially refer on the patient, should they need to be referred on, etc. Whereas page 2 is actually has a totally different purpose, because it's trying to find out all the things which are in the patient conflicting with their ability to recover. So page 2 is absolutely the most interesting thing. Page 1 is who cares. Page 2 is where you find out how the body is not functioning, and it's when you look at that, and when you're trying to understand why would somebody's 6-year-old history of a kidney infection now be relevant to their recurrent sprain of their ankle. Why would that be relevant? Why would somebody's 2-year-old sinus history now be relevant to their TMJ pain? That's a bit easier to put together. But these prior things leave legacies. Those legacies are the mechanical interruptions, the somatic interruptions to physiology that persist and lead to compromise. And so in that context, those legacies are the osteopathic version of germ theory or terrain theory, and so on. And they allow for the mental and emotional add-on tensions into the body and so on. So we're going to try to use your case analysis in a way which helps us to move away from the tissues causing symptom, small biomechanical perspective, out into this physiological construct of a structural interruption of self-regulation. All right, so let's just have a quick say. Okay, so very originally then, A.T.Still was obviously very hands-on. He thought there was a physical cure for everything. He didn't necessarily like all the chemistry that went on because it was so poisonous. Little John, in fact, wasn't quite so awkward about pharmacology and drugs. So Little John didn't necessarily say that osteopathy should be drugless as a system of healing. But what he did say was that when you have a load of drugs, regardless of what they are, it actually changes the body's physiological processes, and it often confuses and confounds the actual diagnosis as to what's going on. So whatever you're taking disrupts the body's normal responses and changes things, so you can't really see what's going on underneath. So that was Little John's objection, which I think makes more sense. These days, again, a lot of people talk about psychology and the mind body connections and biopsychosocial perspectives as an interpretation, and people seem to think that early osteopathy didn't have this psychological perspective, and therefore it needs to be added in. But what I was just going to pop in briefly was that actually it may be that A.T.Still did have an awareness of psychology, but the vocabulary in the late 1800s was quite different, and his version of being patient or person-centered was around the way of if you give reverence to their body, because the body essentially was God made or heaven sent, then the body is not divisible from that person. That person is their body, and so exploring them, their body, was exploring them, and that when, from a very, if you like, religious perspective, there would have been lots of interesting quotes, from this is one from the King James Bible that Still would have had, and an osteopath that we mentioned before, Jocelyn Proby, often quoted. He said that under God's control, all the different parts of the body fit together, and the whole body is held together by every joint with which it is provided. So when each separate part works as it should, the whole body grows and builds itself up through love. So you're getting a perspective that looking at people individually, it's a very important thing. You have to explore each person because it's all God given. So the point wasn't that it was an ideal form, it was understanding how that person can be made to better fit together is the search or the inquiry that you're looking at. And also don't forget that early osteopaths and A.T.Still had this very spiritualistic but other, like Native American heritage, which gave a completely different perspective on spirit and the way that the spirit inhabits the body and how it all fits together and how that relates to health and function and healing. And so probably in amongst A.T.Still's background, he pretty much had biopsychosocial medicine and mind-body perspectives all wrapped up, but through completely different language. So it's just something to bear in mind. And there's another quote about how lots of different theories of health and healing, whether it's American, Indian, whether it's sort of a Greek, you know, wherever it's come from, whether it's come from the Bible, it doesn't really matter. So many people have this idea about having all the parts of your body together, that for A.T.Still it wasn't necessarily a mad idea or even a very strange idea. It was that, you know, when you put bodies together and mold it and bring it all together, if you like, in what God is doing, or gods are doing, if you like, was shaping man in his upright form to be something really quite special, so that man could then essentially stand up, look around and observe things differently than beasts on four legs. And so man could have a completely different life, completely different agency, completely different volition, because of the posture that man has been given, in inverted commas. So I quite like the looking around the ideas that were surrounding the early osteopaths, because I think it helps us understand their writings a little bit more. And around them at the time were also things like the early understanding of the autonomic nervous system. Now I've completely, oh yes, who's heard of Professor Yannick, who does all the autonomic nervous system lectures? He's written all sorts of autonomics and pain books. Anyway, it doesn't matter, but there's a huge understanding now of the autonomic nervous system and so on. Back in 1900s, the chap who was really at the forefronts of this was a guy called Pottinger. If you've never heard of Pottinger, look it up. And this I have to say, when I was training to be an osteopath, this book was my absolute Bible. I love this book to death, because it's a description of he's not an osteopath, but it's a description that fits so well with how osteopaths were trying to learn how to fit different tensions in different parts of the body, how they're trying to relate it all together. And the emergent view of the vegetative nervous system was really something which helped osteopaths realize how things were tied together and how you could influence one part from another and so on. So there's lots of different constructs around which helped inform osteopath development. And I'm going to put one more construct to you, which is not, for example, just a scientific thing, such as the vagus nerve goes here, the sympathetics go here to this segment, to that segment, they synapse here and so on. So there weren't just, if you like, specific details. There weren't just religious and spiritual sorts of details. There were also phenomenological again, we come back to this sort of ontological sort of an epistemological background, because surrounding people's idea of is truth absolute, or is truth, what can you know about a patient? Does it depend? Can you interpret things in a number of different ways? There's lots of people which talked about science in a completely different way to, if you like, positivistic, mainstream allopathic sort of medical people. And they were saying that the perception of the patient, or the perception of the practitioner, or the perception of the researcher, the observer, was critical. Allopathic medicine says that it's irrelevant who's looking, they're always going to look and find the same thing, and there should be no influence from the looker onto the thing being looked. Whereas these guys were saying, actually, that's a nonsense, because whoever looks at it alters it. Whoever is interpreting it will interpret it individually, and it all depends. So, if you're looking at it in a dark light, you're going to come up with one answer. If you're looking at it in a different light, in different contexts, then you'll get a different answer, and that's perfectly acceptable, and each truth will be valid. So your allopathic person wants to find only one thing which is true, and doesn't like being told that other things have been identified. Whereas these guys are saying, yeah, but so what? Lots of things are true, and it's okay, and you can move between different truths. And so these days, a lot of the qualitative methodology, as you would have picked up, is all about phenomena and perspectives, and interpreting things from one's own perspective. So of course, as an observer, as a researcher, it's pretty, excuse my French, beep beep, impossible to separate yourself from the thing being observed, or from the phenomena going on. So there's lots of shared constructs between practitioner and patient. And if you look at George Estefas's paper about the inactive inference in osteopathy, what he's saying is obviously that the two, your patient and your practitioner, you come together and you work it out between yourselves. So if that patient goes to see another osteopath, they've got to work it out between themselves, and there will be a different inference between those two compared to these two. So it's all relative. And if you go back before these people, whom are in the from like 1900s, 1920s, 1930s onwards, if you go back to whom these people were being influenced by, they were ultimately being influenced by these guys, Kant and Hegel and Goth. They're all just names, don't worry. But when you get to these guys, again, they're all looking at different types of phenomena and perspectives. And if we come all the way back to Goth, or Goethe rather, in the 1700s, what they're saying is that they were saying all the way back then that how you look at it is really interesting, and that each time you look, you're going to capture something different. And he had this really interesting thing about Goethe had this really interesting thing about looking at leaves and things. And so this would be one leaf as it grows from a baby leaf all the way to a mature leaf, etc. This will be another leaf. So it first has its sprout, it grows, it develops, and so on. So it has different stages in its life cycle. And so your positivistic person would say that's the same leaf, it's just growing at different times. Whereas Goethe would say, no, each snapshot has to be taken in its own context. So this leaf is not the same leaf as this leaf, and it's not the same leaf as this leaf, because its form is now different. It will have a different function than this leaf, even though ostensibly it grew out of it, the earlier leaf. And this is a bit like osteopathy. Each time you look at the person, they've moved on. You may well have moved on, but they've moved on physiologically. Every time something's happened to them, the environment of that leaf or that body or that person will be subtly different. So you have to view them as they are then. And obviously you can try to see how things have accumulated and how things might move forwards, but you've got to continually look afresh each time. If you take that on board, you then realize that you can't make one diagnosis. So you can't, on the first visit, on your initial patient case history and examination, you can't make a diagnosis which then holds for the next 6 treatments. It's ridiculous. You can say, well, they still got a torn anterior cruciate. So in that sense, the diagnosis is persisting. But every time that, you know, life has happened, every time their body has continued to adjust, every time there's been attempts at healing, every time, you know, other things have occurred, the whole tissue status throughout their whole body will be interacting with that torn ligament. It will be doing it differently each time. So as you're trying to help them each time, you're going to have to reconsider how the body is still being interrupted with each time. So you have to, if you say you've got reflective practice, what it means is that your diagnosis in the context of how you're going to help them, that diagnosis, as in how am I going to develop a management plan, that can never be the same each week. So to have a management plan which is broad, following on from a small, minute reductionist tissues causing symptom, one moment in time identified factor, the two constructs and paradigms don't fit. So in practice, you end up doing whatever you feel like. And there's this tension in the fact that it doesn't fit with how you're supposed to do your evaluation. It's because they're on two different paradigms and they aren't doing the same thing. So rather than scrapping the fulsomeness of what you do in management, which is what your modern academics might want you to do, scrap all that and just do some small bits. What you want to do is scrap all of the way that you do your original diagnosis and your orthopedic testing and your neurological hammer on the knee. You change that to make it correlate with what you're ending up actually doing in practice. And that's the bit to change, whereas I think the profession is trying to be pushed to do something which fits with this artificial construct of tissues causing symptom minimalistic orthopedic musculoskeletal physical assessment, which is not the physiological dynamic that osteopaths originally were discussing. All right, so I'm going on a bit and hopefully I haven't lost you. But as I say, that there's so that essentially where we've come to then is when you put your hands on, and when we come to do things in the practicals, we will not say, now I'm doing fascia, now I'm doing fluids, now I'm doing muscle, now I'm doing ligament, because that's completely ridiculous as a construct. You're assessing all of the tissues all of the time, and you have to work out how everything's going together to have a physiological output. So you have to learn to juggle a lot more and get out of the habit of saying, well, I'll do visceral now, or I'll do mechanical now. It makes no sense. So we're going to try to get you to have a blurring of all of those margins, how to monitor many things concurrently, both near to you and far to you in the patient, and for you to develop flexibility into your interpretation of the tissues. So you stay on the same tissue and you interpret it a number of ways, both locally and globally. So we want to really try to get you to do movement as physiology, immunology, fluidic communication. That's the point of your maneuverings, so that you can understand the communication within the tissues, whether that's fibroblastic communication, synaptic, proprioceptive communication, whether it's osseous, periosteal, whatever communication, whatever signaling is going in there. When you're moving the tissues around, you're not really doing range of movement. end feel physiological barriers. You're not being that boring and two-dimensional. You're trying to work out qualitatively and interpretatively, if you have a change in joint or tissue functionality, what's going on, what disruptions are occurring, and what that might mean in terms of neural signaling, fluid signaling, physiology distant to you. And as you're working from one tissue through many tissues, and you're trying to, if you like, use that tensegrity model and diagnose the foot from your elbow, how do you interpret many tissues simultaneously and get a perspective of tissue damage or normalness across the patient from just one or two handholds? How do you pull it all together and have a very multi-layered perspective from just a few handholds? So that's what we're going to try and do. And I'll set you a little exercise at home. This will be something that you can play with a friend. So you need some potatoes and some cling film, and you want a shiny table. So something where the cling film won't stick to the surface. So it's a bit like that, you know, the tablecloth on the restaurant trick. So you're going to lay your piece of cling film out. Two people either side. One is going to hold either corner and pretend to be a practitioner. The other person is going to sit opposite. They're going to have their potatoes at the ready. And then the person holding the cling film, which is supposed to be your body, it's supposed to be some tissue. You shut your eyes. When your eyes are shut, the other person will place a potato on the cling film, therefore tethering it down a bit. And providing you don't pull too swiftly, like the tablecloth trick, if you just tug gently at the cling film, you'll obviously find tension points in the cling film because the cling film is going to be anchored down by the potato. So if it's the potato is close to you, it'll feel, you know, anchored differently than if the potato is a long way away. You'll get a different amount of play in your cling film sheet before you take up your slack to reach that far potato. And the idea is, so you shut your eyes, you have to guesstimate just by gentle teasing of the cling film from a couple of points. You have to guesstimate where the potato is, and you have to try and reach out and touch it. And it's surprisingly difficult. So those of you that are confident will invariably go a bit wrong. So you can surprise yourself as to how good or how bad you are at locating from just pulling your cling film. So anyway, that's just a little bit of an exercise that you can do. So when you're examining, then, as we go through all of our practicals and all of the rest of the course, what we're going to try and do is look at the whole person in their oddity, with their cumulative lesions from their past medical histories, which aren't going to kill them because they haven't got cancer when they walk in if they've had a pain for 10 years. So you're going to look at their oddities and you're going to examine all of them, irrespective of where the symptoms are, because the symptoms per se are the thing that you come to last, not first. So you need to find out in what way their body distortion, how distant they are from ideal or good functioning, that distortion will be disrupting them physiologically, and you have to think of how is that relating to them physiologically and symptomatically. So if you can somehow match their symptoms with their body distortion, then you've got a management plan. One last name that I'll give to you for now that you may very well never have heard of is Catherine Cools, who again was faculty and past student of the BSO in the 1980s, etc. And she did a bit of research, which was to literally try to put together people's diseases, problems, and so on over the years. So the last 10 years of their history, the last 20 years of their history, whatever they had or had in the past, whether they've still got it or not, it doesn't matter. Note all that down. Then separately examine them and to find out. So if person A had all these restrictions, but they had these diseases, do they correlate? So the number of people that had restrictions here, here, and here, did they share a common set of presentations, you know, historically or currently? So did mechanical postural deviations at certain points accumulate and correlate to common disease development and progression? And actually she found that in quite a reasonable number of cases there was some sort of correlation. And so she's an interesting piece of research, because people don't do that sort of research now, and I wish that they did. It was never properly published, so it was a quiet little production. There's this silly little spiral bound book. I put it on the website for you. It's not, you know, it's not you know, like you might find a modern biomechanical paper. It's not, you know, written for publication in 2022, but nonetheless I think you'll find that it's really interesting. So I've popped it in there that you can just see in the recent history there were people still trying to get back out through that rabbit hole, back out through to that original funnel, if you like, trying to re-look at that early original universe, even though they were, if you like, sitting in and residing in or trying to survive in their parallel modern construct. So we're pretty much at 9 o'clock. I was just going to sort of chat through a couple of case histories, but we can do that another time. That's fine. So I'm going to wrap up my talk, my introductory talk, with that, and essentially put it over to you to see if you've got any questions in the last sort of few minutes. So I'm just going to turn off the recording.